So currently, I practice in the outpatient setting in San Bernardino, in the Inland Empire. It has a similar setup as far as the makeup, the ethnical makeup of the population that you serve. And I also serve in the inpatient setting, everywhere from emergency room to the general pediatric wards to the intensive care unit, Loma Linda, Riverside, and as of recently in downtown LA, so with White Memorial. So I have a little bit closer to you guys. All right, and then as was mentioned before, and I think this is really important, I do have different leadership positions within medical county societies, and this allows me to work very closely with family physicians as well as they provide a huge proportion of the pediatric care, as well as more surgical specialties as well. We get to work together and how can we improve healthcare access for the people, for the patients that we have in our communities, and also in a larger level at the state with the California Medical Association, and then also the AMA with the American Medical Association. All right, so this is like a very quick blurb about me. But it's really enough about me. This is much more about you. And when I was first approached to do this talk, I didn't know much about LA bus babies. And then I got to learn more about it. And I was so amazed about all the wonderful work that you do. I didn't know that this existed, and it's amazing. I want to learn more about y'all and see how we can bring this back to my hometown, San Bernardino. It's amazing. So thank you so much for everything that you do. And thank you for being so interested and invested in the patient's care and coming to this talk. So the agenda obviously is a little bit off because one, I was late and I apologize. And also because we will still go through these 3 sessions. So the first one, we're going to focus more on the first month and what that entails. Why are we so paranoid and we want to see the baby so often in our office the first month of life? And then also then going their second section, focusing more on the 2nd, 4th, and 6th month visits. And then from 9 to 18, mention them all together because they tend to be more similar. Okay, I'm just gonna jump into the first one. So we're gonna start out with the first month timeline. So we go all the way from birth to 2 months in the first session. So my question to you is, how many visits should a baby have between birth and 2 months, not including the 2-month visit? From your experience, what do you see, and how many visits do they actually come to the office for? So you can respond between 0 all the way to 4 visits in the first time, and you just send in A, B, C, D, or E, depending on what your answer is. Okay, so not counting the 2 months. I'm glad that no one said 0. I'm very happy. That's great. So the correct answer is actually the bare minimum is 2 visits. There's times that we do see them more depending on what their needs are and if there's different medical necessities that they have to come see us more often. All right, so that's the correct answer, but the bare minimum. Okay. All right. So, oh no. There was I know, and my sister actually worked so hard on it, and I feel bad. Okay, all right, so we'll start with birth, so you know everything that happens in the hospital and then where we come in. So when they're born, everything's fine and dandy. They get their Hep B vaccine. This is very important. You'll have some parents, and if they refuse to get the Hep B vaccine, we do have to counsel them, and it's okay as long as they get it by 1 month of age. Absolutely, they have to get it by 1 month of age. The reason is, if the mom has Hep B, or even most of the time, when they don't have a lot of prenatal care, they don't get tested for everything. So we don't know if they're Hep B positive or not. But if a baby is exposed to Hep B, there's a 90% chance that they will have full-blown liver disease by the time that they're 3 years old. So a majority of them end up with the disease if they're exposed to Hep B. So that's why there's this huge national campaign to push everyone to Hep B by the time they leave the hospital. It doesn't have to be the second they're born, but by the time they leave the hospital. At our practice, at our hospital, they tend to give it on their way out. Literally as they're walking out the door. So they're like, oh, if the baby has a fever post-vaccination, which often happens, then the parents, it's not something that we have to keep them in the hospital for 48-hour observation. So we always encourage everyone to get the Hep B by the time they leave the hospital. Another thing that's really important when they get born at the hospital, and why we encourage hospital births versus at-home births, is the newborn screen. So this is it varies state by state, They take the baby's blood and then they test it for different diseases. It's very important for metabolic diseases. So these are something that otherwise we would not pick up till it's much later and it's too late that we can make a difference. Or if they have different blood disorders, or if they have thyroid problems. So they do a quick screen, again, it varies state by state. But for example, in California, we also screen for cystic fibrosis. So that way we're able to plug in the patients early on with the specialties that they need should they be positive. One of the catches though about this is if you are positive for something or borderline positive, the state then sends you, the parent, a letter, a pink envelope, like this is abnormal, please go see your pediatrician. And then they also send one to the pediatrician. Oftentimes when they leave the hospital though, they're not established and they don't have a pediatrician in mind and they don't know who to send this letter to. So then the letter gets sent to the hospital and it has to be processed by the hospital till it gets to the newborn nursery. Then the newborn nursery, then they're like, oh, where did this patient go? Let's try to find their home address, and hopefully we do have a home address for them. Hopefully we do have a phone number that we can call them. But that are so many different opportunities to fall through the cracks, and this is why we heavily emphasize for patients to be seen early after they're being born, establish a medical home, and that way we as the pediatricians can follow up and we can call the state and say, hey, was everything normal on the newborn screen, anything abnormal, should these letters get lost in the mail? Right. Another one is the hearing screen. So this also has to be done by the time they leave the hospital. There's many times that we pick up language delays when we see them when they're 1 year old, 2 years old, and the number one reason is actually hearing deficits. It can be from a simple infection that mom had during pregnancy, and no one thought anything of it. It could be congenital, they're just born with different nerve problems and they can't process. And we need to pick this up as early as possible. So if they need to get hearing aids, we can get them early on so they can start cooing and babbling at their appropriate ages. Or if there's nothing that we can do as far as we can start training the parent how to do sign language and how to communicate to their baby. Then we have the cardiac screen. No matter how many times a mom goes to, and she's a perfect mom, and she goes during the prenatal care, she gets all her ultrasounds done, that is all wonderful, but there are still times when we cannot pick up all the cardiac diseases from the ultrasounds. And they're born with different disorders that we need to pick up in the hospital when they're born. We do a very thorough evaluation of their heart and their system, their vascular system, that if they're born at home, we can't really do as well. And then this is something that can also present later on, so it can be missed in the newborn phase, but presents like at 2 weeks of age or 1 month of age. So we continue doing these cardiac exams every single visit they come to make sure that that's not something that we're suffering from. All right, the Red Reflex Screen. How many of you remember the fabulous pictures back in the day before all the iPhones when we had all the red dots on the eyes, right? And we had to get the corrector and make sure that everything's fine so you can display your pictures. Well, that actually was a really great sign for the health of the eye. If we do the Red Reflex Screen, so we can see in this baby, one of the eyes has the usual red dot, and that's actually a really healthy sign. It tells me that the eye is intact and we have a good reflex. The other eye you can see is white, so it doesn't give me that red reflex. So that usually is an indication of a cataract. And it's not something that you can see just looking at the baby. It's not going to be, like our older patients when they have a white cataract and you can see it's in front of their cornea. Oh, sorry. Okay, so you can see with this one, it helps us detect this as early as we can. I just saw a baby, was a 4-month-old yesterday that had bilateral cataract, and they had to go and get this removed surgically, and then they go and have lenses placed in about 2 weeks after it heals. Otherwise, they can't see at all. Their vision essentially is legally blind. And if we don't catch this early on, babies' brains are pretty amazing. They're very plastic. So if the brain says, I can't really see with my left eye, I can't process any of that information, that side of the brain shuts down. They never use it again. They rearrange it to use it for other things. So it will never be used for optical information ever again. And then the optic nerve also starts to die off, and also the vessels. So we lose that eyesight forever. So it's very important that we catch this early on. All right. And then of course, we always do a lactation consult. I by no means am an expert when it comes to breastfeeding. I know my textbooks, 2-3 options that I know to go to. I don't have any personal experience from breastfeeding. So that question always comes up. I always go to my lactation consults. They know they're so much better and they have so many different shield nipples and the brown nipples. I don't know much about that. I'm very limited in my knowledge, and we rely so heavily on the whole team to help us with the mom and help us with different techniques. And then lastly, the 24-hour bilirubin level. So this is one of the main reasons we don't discharge a baby before 24 hours, even if they're doing perfectly fine. We definitely have some moms on their 9th baby, they're like, I'm good to go, I know what I'm doing, I feel fine, I want to go home with my baby. And that's great, and we're very happy. We want to empower them as much as possible, but we need to have the 24-hour bilirubin before they leave. And I'll tell you in a little bit why. All right, so the first visit, 3 to 5 days. I definitely want to see them in the office by 5 days of life. It's absolutely mandatory. All right, so one of the first things that we do a postpartum depression screen. So I have a question, so let me switch over to the other one. And I know that you see the families a lot more often than we do. So I want to ask you, how many moms do you think have postpartum? Great. So again, if you think it's, share it. Okay, so if you think it's less than 10%, type in A. If it's 10 to 20, type in B. 20 to 30, C. And over 30, D. So, majority of y'all said 20 to 30%. The literature actually shows about 15% of moms have postpartum depression. So, postpartum blues, that's definitely a higher percentage, but true depression is 15%. And then postpartum psychosis, which is the worst case scenario, is actually not even a recognized diagnosis by the DSM and the psychological diagnosis that they have, because usually that ends up being women that already had bipolar disorder, and this gets finally triggered and it gets a full-blown manic episode. So postpartum depression, where they need medication, is about 15%. All right, back to the presentation. I'm sorry? Yes.
No, we just thought the number was a little bit higher, but you already stated with medication, so that I can see why it would be a 50%.
Yeah. So the true postpartum depression, where they meet the criteria over like 2 weeks of the symptoms, and they're crying, more than several days a week, and they're thinking, worrying more excessively than usual. Postpartum blues is a much higher number, but that's not necessarily something that we treat. We address it, but we don't do medications that early on. Okay. The other thing that we do at the 3 to 5 day is the bilirubin check. All babies are going to be yellow. They all are. But we need to know how yellow. So the reason that they turn yellow is when they're born, they get extra blood from mom, kind of like the extra last push from the placenta before we cut off the umbilical cord. So the baby then needs to get rid of all this extra blood. They need to break down their red blood cells. The breakdown product of the red blood cells is bilirubin. So then they have to eliminate this. So they have to process the bilirubin, and then it gets eliminated either through stool or through urine. If it doesn't get processed, which is often the problem that we run in the baby population, is it gets deposited in the skin, and that's when they get so yellow. So that can easily, when we look at them and we see that they're so yellow, we're like, oh, you're still working on processing your bilirubin so you can eliminate it. But there's so many studies that show our clinical exam is not very reliable to say what the bilirubin, just because one baby's more yellow than the other, it does not mean that their bilirubin is higher than the other. And it also varies with ethnicities. It's much harder the darker the natural skin is for them to present as yellow. The other signs that we see, you'll see that the whites of their eyes are turning yellow. And then they also can have much more severe symptoms. And I'll tell you why we get so worried. I check the bilirubin in all babies that walk in. We all do. it depends how high the level is and how fast it's rising. One of the problems is they're not getting enough milk or formula, whichever the option is, and they're not able to eliminate this. The other one is they don't yet have the enzyme to process the bilirubin. When it gets a certain level, it deposits in the skin. Once it gets a little bit higher than that, it becomes very dangerous because it gets deposited in the brain. And what we call that is kernicterus. And you can see in this biopsy, Brian, you can see where it's a little bit more yellow, and that's where the bilirubin got deposited. The problem with this, it's not reversible. There's nothing I can do once it gets to this level. And this can cause deafness, blindness, developmental delays. It can cause them to have seizures for life. If they make it, most of them, they're going to die once they have this level. So that's why we are so worried. And when we see a borderline high level, I have them come the next day. Let's check it again. Let's see where we're at. We're still borderline coming again. Maybe it's time to start supplementing with formula. Now let's see what can we do to help the baby. Or we try to do phototherapy. Unfortunately, the problem that we run with some insurance is that they don't cover the phototherapy at home. There's this wonderful Billy blankets, what we call them. It's like a blanket of blue light. It's like the movie Avatar, if you watch that. You wrap the baby in that and you send them home, and that blue light is very important because it helps them process the bilirubin that's in their skin. And we always tell them no diapers, no clothes, nothing, just expose them to all the light that you can. And unfortunately, majority of insurances don't cover this for them to take them home, and that means we have to admit them to the hospital for phototherapy. So we try to avoid admitting them, and that's why we do such frequent checks to make sure it's not like, oh gosh, no, but if it's a Friday, and I'm not gonna be able to see them Saturday, Sunday, that's when we run even more trouble, and we have to route them through the emergency room or a direct admission to the hospital. And this happens. I just had, gosh, like a week ago, I was at White Memorial and I admitted a baby that had to go down this route. And when it gets to this point, we have to do an exchange transfusion. We have to place a central line through their jugular, take out their blood, give them new blood so we can clean their blood of all the bilirubin. So it's quite dangerous, not only the last minute resorts that we have, but the outcomes as well. Okay. So with that comes the milk production. A lot of times, especially new moms, in the first 3 days, they tell us, no, I don't really feel like I'm full. I feel like I know the baby's trying to latch. They're really frustrated, but I don't feel like I have the milk. So this gives us an indication, when we see the high bilirubin, usually that comes because we're not producing enough milk. And we want to encourage the moms to breastfeed as much as possible. But there comes a time when you tried breastfeeding, the breast milk is not in yet, we have to supplement the baby. The baby has to eat. So at that point, we do encourage to start supplementing. We do want to encourage the moms to continue breastfeeding through this, hoping that the milk does come in. So what I suggest to moms is breastfeed, and then at the end, top them off with formula. So put them on, 10 minutes, 15 minutes, whatever your preference is to bond with the baby, and then give them formula 1 ounce, 2 ounce, see how much they'll take. If they're taking 2-3 ounces every time, that tells me you probably don't have a lot of milk. If they're taking 1 ounce, probably in between, you're getting there. So it also gives us an idea where they are in their milk production. So a quick way that we can also tell this is weight loss. So we look at the babies, and that's why we also meticulously weigh them 1,000 times without diapers, without any other confounding factors. And we look at how much they lost weight. The max that we will tolerate ever is 10%. Once they hit 10%, we have to hospitalize them because we want to make sure that they're getting the fluids and the nutrition that they need. When we say 10 pounds for them ends up being 8, 9 ounces, right? It's not a whole lot. But to give you an idea, I weigh 160 pounds. How much I weigh. So if I lost 16 pounds in 3 days, I would hope that my friends are very concerned about me and take me to the hospital because that's a lot. So even though it's only a couple of ounces for the babies, it's really important that we translate this what the percentage ends up being for. See them in the meantime. So now we have the 2-week visit. I have to see them in 2 weeks. So the 2-week visit, we also talk about postpartum depression. We want to make sure that everything is still okay. And at this point, we have 2 weeks. So once you have the magical 2 weeks time frame, then you can also make the full diagnosis of depression. Because you can't say, I've been sad for 3 days, and make the declaration of postpartum depression. We need the 2 weeks to prove that it's something that really needs to be taken more seriously. All right, and then we also talk about home dynamics. How is dad doing? How's the husband, boyfriend, or whatever the role is of this person in the story? How are the home dynamics at home? You have probably a lot more interaction with the parental figure than we do. They rarely come to the office. It's usually just mom and baby. Occasionally we will see the boyfriend or the dad. But you have such a more intimate relationship with the families, and you get to see that dad and see how he interacts with the baby. How is he doing? And that is so very important. In San Bernardino, in the Inland Empire where I'm at, we are actually the capital of NAT. NAT stands for non-accidental trauma. So the classical story is, mom just had a baby, she had to go and run a quick errand. She was gone for maybe 2-3 hours. So she left dad, boyfriend, husband, whatever he may be, fiance, to take care of the baby. The primary caretaker has been mom all along. Mom knows the crying, she knows when the baby needs to be changed, when the baby has to be fed. Dad doesn't. So then usually they tell the baby, stop crying, right? The baby's crying, mom's gone. And then change the diaper, still crying and crying and crying. Try to feed the baby, still crying and crying and crying. And they get very frustrated. And what we see is they pick up the baby and, like as you would your friend, when you go out to the bar and they're being silly, you grab them by the shoulders and you shake them and say, please stop, right? So they do that to the baby, like stop crying. The problem though is they don't have good neck control. So when you shake the baby, they essentially have whiplash back and forth. And the veins are still not fully developed in the brain. They're still very, very fragile. So every single time we do this whiplash effect, you have the hemorrhage. So they break and then you have the bleed inside the skull. And this can be anywhere from, okay, we're just gonna have to monitor you in the hospital for a little bit, you got lucky this time, to you're gonna have seizures for the rest of your life because this is permanent damage. And you didn't get, because there's so much blood in the brain, you didn't get enough oxygenated blood to the brain, to even death. So death sounds like an ultimatum, right? So let me ask you, how many, so the last data that we have from the CDC when they aggregated all this data was from 2014. So how many babies under 1 year do you think died from assault? And this is what we call assault. So if you think it's under 50 for all of the year, so this is an entire year, okay? And then we're talking about death. So we're not talking about we end up with seizures for life or we're developmentally delayed. We're talking about death. So under 50, A, 50 to 100, B, 101 to 150, C, 151 to 200, D, and over 200, E.
This is for the whole United States?
Yes, for all of US. All of US, not just California. Not just my county, where we're the capital and we have the highest rate. You can change your answers, it'll have the most updated, your last answer. So the actual number was 249. And these are babies that died. We don't have a number of how many end up having, being comatose for life, being ventilator dependent for life, having seizures that they have to take 3-4 medications a day to kind of control them. So I think it's a huge number to reflect on, 249 babies, and the classical story is always the male figure was left to take care of the baby, they didn't know how to, and they got very frustrated. There also, to be fair, there's also, there tends to be substance use or problems, a history of it in the household. Maybe they weren't able to get whatever drugs that they use, or they were using the drugs when they were left to care for the baby, and that leads to obviously huge problems. Yes?
You said it's a male character?
Usually it's the male. Very rarely can be the female.
What percentage is that number?
That I don't know. It's not, the CDC doesn't have that. But as far as, gosh, like in all the training that we've had, like as during residency in 4 years, I had only one female perpetrator. Everyone else is usually the male. So it's personal data, statistical as well. Everything that we learn in the textbook, it's always the boyfriend. I'm not saying blame, always the boyfriend. And we, from a medical standpoint, we don't make any accusations. We have the forensics team that comes in any single time we address these children, we see them. And the story never makes sense of what happened. We see this in children that are older. For example, a not so deadly final, I guess, outcome. We have children, like 2-month-olds, that they come with fractures of their legs when they were twisted, like the spiral fracture. And the story is, oh, the baby was walking and they took a turn. A 2-month-old doesn't walk. So the story never makes sense. And that's the first clue that we have, that developmentally the story that they're trying to tell us is not appropriate for that age. Or if there's a fracture like along the head, oh, the baby rolled out, their baby was rolling on the bed and then they rolled over. Again, a 2-month-old doesn't really roll over. I wouldn't expect them to have that strength. So the story that they come up to help us to explain the injuries I shouldn't say never, are very unusual for the developmental age that the baby is at. And we see them 2-month-olds, we see if they shake him on the chest, that's also very common. They grab him by the chest and shake him, and we'll see fractures on their ribs. Both in the front and the back, we can see that. So it really varies the outcomes that we see. And it doesn't have to be just the bleeding inside the head. This tends to be the most dangerous one. Yes?
I want to say thank you for that information because I did have a case like that, not with my client, the baby, but with the sibling. And what you're saying, it was the dad, the male. He was left alone with the baby while mom went to do something. And it happened, and he did face some time in jail for that. But the effect that it had on the family after, to now that I saw my client, it is still there. And I forgot what else I was going to say. But that kind of shares a little bit of the information I need when I go in the home when a mom is sharing a story like that.
Yeah. No, thank you so much for sharing that. And you're absolutely right, it affects the family. So even when the first accusation is made in the hospital, we have to call CPS. We as the physicians, we don't get as involved with that. We have the social worker and they take, so we try to be as objective as possible. And my job is not to say you're to blame, someone else is to blame. That's not my job. My job is to take care of the baby and have the best outcome I can. There are personal frustrations that I have dealing with this. You'll see sometimes the perpetrator, and we're all kind of suspecting who it is. They'll come and they'll be very interested, like, how's the baby doing? I want to be there, I want to cuddle, I want to come to all the family meetings. And you have your suspicion, but you have to keep on the objective face. You have to present the data as much as you can. So it is quite difficult. And then the other thing that breaks my heart, and this is completely a personal opinion, is you have these children that are so devastated, but they're not brain dead. They're not. But they're ventilator dependent. They're now blind. They can't hear. They have maybe one reflex left, so you can't call them brain dead. If mom decides to pull the plug, it's now the boyfriend, dad, whoever, is facing murder. If they don't pull the plug, it's assault, life versus a couple of years in jail. So then this mom that usually has some sort of dependency on the male figure, they're in a relationship, she's put in such a difficult spot. And what's best for the baby, what's the quality of life, and that's something that I can't answer, that's only something that the mom can answer. And how do you balance that with your relationship? So it's a very difficult road to navigate. Okay, any other questions on this subject? And it does break up the whole family, because once the kid is labeled as such, or we have to remove all the other siblings in the home until the investigation is complete. Because we want to make sure that no one else is being hurt. And when that happens, obviously the siblings don't always end up in the same spot, so then the siblings get dispersed among different foster homes or different centers, group homes. It's never the same. It's never the same again. And they will forever, you're right, they're forever haunted by this. All right, so home dynamics is very important. So then we also want to make sure that they've regained their weight. So this is one of the medical aspects. So we allow them to lose up to 10% of the weight, and then we want to make sure that they've regained it all. At 2 weeks, they have to be back at birth weight, no later than that. Again, if at 2 weeks they're not, we are supplementing like crazy. If they're not working, we have to hospitalize them. There's something else going on. Yes? we have goodness gracious, I'm blanking out on the name, but it's the 4 questions where we ask them, you know, if they're feeling more sad than usual, if they're more worried than usual, if they've ever had thoughts of hurting the baby. No, it's an in-between. It's not 2 questions, it's not 9 questions, it's 4. So it's in between, and that is because it's partially with the ASQ that we combine it, and we've made our own for our clinic where we combine the 2 and merge them into 1. Okay, great. And then we also talk about cord stump. So at the cord stump, the 2-week mark, it should have fallen off. We allow them up to 21 days. At 21 days, if it hasn't, we have to do more of a workup to see exactly what's going on. We always tell them from day 1, please keep it as dry as possible. No alcohol wipes, which is done quite a lot in the community. No alcohol swabs. And the reason is, any single time we're keeping the skin wet, essentially we're telling the body this is something you have to hang on to. The more dry we keep it, the faster it's going to close off and fall off. If they want to put in a coin, as I've noticed that some parents do, totally fine, as long as it's a super shiny, clean coin. They can put it there, and they think it helps. If they think it helps, sure. Doesn't hurt the baby. Okay. All right, so then again, we screen for hip dysplasia at the 2-week mark, and we talk about the anticipatory guidance with fevers and the sleep safety. All right, 1 month. This is optional. Yes, I'm so sorry.
Usually for the hip dysplasia, how long does it take to go back to the place?
How long does it take to repair it once so it varies on how displaced it is. Because some can be just partially, and we can just be in a harness for about 2-4 months. Some definitely need longer, and the longest I've had, 8 months. But we do adjust the braces as they grow. They're not forever in this contraption. All right, so for the 1-month visit, this one's completely optional. I tend to do it for my first-time moms, especially as they have 1,000 questions come up, and I want to make sure that we have enough visits and we reassure them with everything that comes up. And this one, again, we screen for depression, the home dynamics. This is also when I get a little bit more time with them to see how are they coping? Are they still having time for me time, which is so important? Is family helping? Is grandma in the picture? Is grandpa in the picture? Or aunts and uncles to help out with the baby so they can get a 2-hour break at some point? And then also if they need WIC referral at this point, if it hasn't done yet, usually it's done in the hospital. We try to make sure that everything's tidied up. If they need the community resource center, if they need bus passes to be able to come to their appointments. And this is when we try to really plug them in everywhere they need to. Also because of the first month is when their insurance switches over, and we want to make sure we catch them right before this happens. All right, and the 2-month visit, that's up next. So that's my teasers. We have a quick little break. Okay, do you guys have any questions on this section? Yes?
How long do we do the vitamin D?
They stay on vitamin D until they are fully dependent on, so around like 6 months when they transition to solids. Yeah. Any other questions? Okay, thank you. Do a quick break. 10 minutes? 5 minutes? 5 minutes. Okay, 5 minutes.